Hi Graham, so I'm Stuti, I'm with Graham Pike, that's from Swindon, that's somewhere near Oxford. He's a IPC practitioner.
Yes.
And today you talked about sustainability in IPC. So it was a very broad but important subject, and it was really eye-opening. So in front of the urgency of the situation and the huge actions that we can do, what would you suggest for our colleagues that they could start from so that it's not that impressive and overwhelming?
I think it's important to start by thinking, what is the link between sustainability and IPC? Because traditionally, sustainability can be seen as the enemy of IPC or the other way around. So people might think we cannot make healthcare more sustainable because it increases the risk of infection if we reuse things more or treat it in different ways. But actually what we need to think is, we IPC professionals, we've got the expertise to help us make this change safely and actually to champion the ideas, because people will think IPC professionals will say no. Mm-hmm. We need to be the ones thinking of the ideas. And I can give a few examples, I suppose, where actually some of the changes we make, they are better for patients, they are better for the planet, and they save money as well, so that everybody wins. If I give some recent examples in my hospital, so we've been looking at simple things actually. So if you think about the things that we use every day, let's look at it all, and as one of the other speakers said, be curious and think, can we do it differently? So something simple like changing the sheets on our beds. So in the UK, and I think probably in lots of countries, in hospital, we change every sheet every day, whether it's dirty or not. And no one does that at home.
No.
And people think they're doing that for infection control reasons.
That's true.
If you speak to staff on the ward, they say we have to. But then you start to think, why? And then you think, actually there's no risk from a sheet. If the sheet is clean, obviously. If the sheet is dirty, we change it. If your patient has an infection, then maybe you want to change the sheet to reduce the bioburden of that particular bug. If they've got a CPE, for example, sure, change the sheets daily. Or if they're immunocompromised. But for many patients, we could change the sheets twice a week.
Yeah.
The blankets, maybe just when they're dirty. So we've started doing that, and we thought this will be unpopular. People will be worried about this. So actually we went out and spoke to the public and we asked their opinions. So we spoke to some of our patient groups, and they were very positive, overwhelmingly positive. So we're just starting to bring that in now. And we know that other countries have done this already. So sometimes it's looking around and thinking about examples in other hospitals, but in other countries as well. Another example actually, kind of similar, and I don't know if it's the same in France, but we have on examination couches, we have a sheet of paper.
Yes.
Yes.
We do.
Why?
Maybe because people don't clean after, so it's on top security.
Yeah, exactly. On the top. So if I go to see my GP, I go and sit in the chair and he examines me. And then I go and there's no paper on the chair. But if he wants to feel my abdomen, I go on the couch and it has to have a paper sheet. It makes no sense.
It doesn't.
It's not impervious, so really they should be cleaning the couch anyway. It doesn't offer any comfort. It doesn't offer any absorbability. It's just something we do because we've always done it. And there was an infection control nurse in Warwick in the UK who looked at this in her hospital, and I cannot remember the exact figures, but it was thousands of pounds a year they saved by stopping using it. They use it for a very few procedures. So if you're doing invasive things, maybe cervical smear tests, maybe you might want to keep
fluids
it. Exactly,
involved.
yes. Or if you're seeing children who are not potty trained yet, of course, or PV bleeding. But for most patients, you don't need it. But people needed the permission of infection control to say, stop doing it. And when we started to talk to staff about it, they would say, oh, yeah, you're right. Or sometimes it's, oh, I've been saying for years we should stop using this. They just need us to lead and to say yes.
That was actually your conclusion. So what you're saying is we should be leaders about that, so we don't have any excuse not doing it. So we should all start at our own rhythm, and we'll be all able to do and make a change.
I think so. I think the couch roll is a good example where people have been thinking they can't stop it because of IPC. And then when you start to have that conversation, you can. So if we're the ones saying, how about this? Let's try this. People will be, and then they'll come to you with other ideas. And another thing I'd suggest, if you don't know where to start, just go and look in the bin and see what makes up most of your waste. It's probably PPE.
Gloves.
Yeah, exactly. So we talk about gloves a lot, so it's time to stop talking. We just need to do it. We need to explain to people why it's such a risk for, not just for infection prevention, but for the planet and the cost as well. So it's worse for patients, it's worse for staff, it's worse for the planet. So yeah, as I said, the time is short, we just need to act.
That's a great conclusion. Thank you, Graham.
Thank you very much indeed.